Alrighty. All right. Well, good morning, everyone, and happy match day to those who are supporting some students in this journey today. I'm very proud to introduce Dr. Allam, who was my chief resident when I was an internal medicine resident. And she went on to do additional training in dermatology. So she's one of those amazing double doctors in the dermatology department with expertise in internal medicine and dermatology. And she's currently faculty in the Department of Dermatology and also director of the Granulomatous Disease Clinic, which is so cool. So very excited to have her here to teach us about skin concerns and can take it away.
Thank you, Ruru. Thanks for such a kind introduction. And I know I've interacted with many of you over my time at UW, so thanks for having me. I am excited to talk to you about management of skin disease in the geriatric patient today, which is obviously a big topic, and I'm going to try and just focus on a few smaller topics, but feel free to ask questions during the talk or at the end. I don't have my chat up, so maybe if you just like unmute yourself, that would be great. Um, so I have no disclosures. And my plan for our talk is I'm going to briefly touch on the changes that occur in the skin as it ages. And then what I really want to focus on is highlighting four dermatologic conditions that I think really require nuanced care in the geriatric patient. So we're going to talk about generalized pruritus, indolent drug reactions, bullous pemphigoid, and then the non-surgical management of basal cells and squamous cells. And then at the end, I'm hoping we can leave time for questions. So if there are any topics I didn't cover that you have particular interest in, please just let me know. So first, talking about skin aging. So what happens to the skin as it ages? So there are a couple of different, pathophysiologic things that change as our skin gets older. So the first thing is that the epidermis, the top layer of the skin, actually thins quite a bit. And what we see is the loss of these reedy ridges, which are kind of the extensions of the epidermis down into the dermis. And that loss of the epidermis makes the skin much more susceptible to shearing forces. The reedy ridges, which are these loops I'll show you in a minute, are actually a really big site for nutrient exchange in the skin. They're really well vascularized. And so the thinning of the epidermis prevents nutrient exchange in the skin. And that also leads to some of the issues that older patients experience. We also lose collagen and elastin as we age, and that's in part related to sun exposure, but in part just related to changes that are natural with aging. And our barrier function declines. So that means that the barrier between the skin and the outside world is just not quite as effective. The rate of repair slows, and then there's decreased lipid synthesis and processing, and the lipids are a lot of what leads to the barrier function. And so that contributes to the dryness that a lot of our older patients experience. And also makes it so that the skin has a harder time recovering from any irritation. So from like caustic soaps or detergents or things like that, the skin just has a harder time recovering. And then there's this idea of immunosenescence in the geriatric patient, which I think is really interesting. And basically, like what that means is that the immune system in our skin becomes senescent, and meaning that it kind of declines over time. And that actually really leads to a pro-inflammatory state. So you'll notice that a lot of the things that we talk about today are inflammatory disorders of the skin. And that's because we really kind of lose our immune protection and get some of these inflammatory issues as we age. And then lastly, there's reduced vascularity, which just leads to poor wound healing and some of that nutrient exchange issues that we talked about as well. So this is an example of skin biopsies in a younger patient, in a patient who has just been aging. And then the last one is a picture of a punch biopsy of someone who has been aging and has had sun exposure. So you'll notice that in the second slide, this is a really good example of epidermal atrophy. So the normal or youthful patient has these like really nice, well-formed reedy ridges that participate in nutrient exchange and are part of the epidermal barrier. And then as you age, the epidermis really thins out a lot. And so it's pretty striking to see. And you can really tell in a punch biopsy when you look at it under the microscope, like how old the patient is. You can also see that the collagen bundles are less tightly packed. And in this slide, what this is really showing you, all this like purple wavy stuff is called elastolysis, or it's degradation of the elastin that happens with sun exposure. So most patients who are older, and especially patients who've had significant sun exposure or have lighter skin, they will end up looking like this when you do a punch biopsy, for other reasons. So how can we prevent skin aging? We can't. Um, but there are things that we, maybe could do to help slow the progression of age-related changes. So the number one thing is sun protection in patients of all skin types. So we recommend SPF 30 or above, reapplying every 2 hours. Sun protection with hats, long sleeve, UPF shirts, which have sunscreen kind of baked into the fabric. Those are all really great tools that can help prevent sun damage. And then tretinoin is probably the other thing that I would recommend to patients if they are concerned about their aging skin. Notably, this is not covered by insurance for skin aging in particular. So you kind of have to bill it as acne, or patients can pay out of pocket. But putting a little bit of that on every night is probably the best thing to prevent fine wrinkles and some other age-related changes. There are things that can treat age-related changes as well. Tretinoin, again, can be helpful, and then lasers can be helpful. Pulse dye laser is used for some of the telangiectasias that we see in aging. Intense pulse light, IPL, which actually not a laser, it's just a particular type of light, but that can be used to treat fine lines and lentigos. And then you can get a blade of resurfacing lasers, which, to be, I don't know, a little simplistic about it, kind of like burn off the top couple layers of skin, and can really get at fine lines and deep lines as well. That being said, I am not a cosmetic dermatologist. I don't do basically any of that. I just recommend sunscreen and tretinoin. But if you do have patients who are worried about aging skin, these are kind of the people I would recommend locally. I think Erica Linnell, who is just up the block from Harborview, is really excellent at thinking about patients' underlying skin color and how to safely use lasers and things like that. So really would recommend her as well as some of these other folks. But again, I'm not a cosmetics person. I do a lot of medical dermatology. So I'm going to really switch our focus to thinking about some of these dermatologic diseases that I think have interesting discussion points in geriatric patients. So first, we're going to talk about generalized pruritus. I would say this is one of the most common things that we see on the dermatology side in our geriatric patients. It can be a really tricky thing to tackle. And I think a lot of the workup and even management of it can be done by the primary care doctor or the geriatrician. So generalized pruritus is, to start simple, pruritus is just itch or the urge to scratch. And it's considered chronic when it persists over 6 weeks, and is really common, especially in elderly patients, as I'm sure you all know. So there are 7 million outpatient visits per year in the US for itch, and 25% of those are for patients who are over 65. It occurs in about a third of nursing home patients. There was a recent Turkish study of 4,000 patients, and it showed that 12% of the patients who had chronic pruritus were over 65 and 20% were over 80. So it really preferentially affects our older patients. There was a more recent US study looking again at around 4,000 patients, and they found pretty similar number, like 20% of patients with generalized pruritus were over 65. And then other studies quote up to 50%. So super common. And I would say in real life, that's definitely what we see. Most of the patients who we see coming in for generalized pruritus are over 65. Geriatric patients have also been shown to experience a higher intensity of itch. And this is really important because itch can be associated with anxiety, depression, sleep disturbance, and poor quality of life. So a lot of different things can cause generalized pruritus or chronic pruritus. And so I'm going to kind of go through each of these boxes to help you build a little bit of a differential around what to think about when you have patients coming in with chronic itch. So from the dermatologic perspective, pretty much like any skin disease that is itchy can cause chronic pruritus. And probably what we see most commonly is that people have low-level eczema or atopic dermatitis that is causing their chronic itch. Psoriasis is another big reason for chronic itch, as well as xerosis, which is just dry skin. And then some of these rarer things I mentioned because I think they're good to think about in someone who's coming in with chronic itch. So Grover's disease, which I'll show you a picture of in just a second, is a really common cause of chronic itch, especially in male patients in the 60s, 70s age range, where they get these like really itchy papules on their trunk. Bull's pemphigoid, we're going to talk in a lot more detail about, but that's a super common cause of itch. And notably, it can present with itch before people get any skin changes. So they can just be itchy all over and then later develop more urticarial plaques or blisters. Cutaneous T-cell lymphoma is a super important one to think about because, again, can just present with chronic itch. And it requires, more nuanced treatment often. There's something called an id reaction where people have often fungus related rash, like tinea on their feet, but then they get an inflammatory reaction elsewhere in their body, and that can be caused by other things other than fungus. But another good thing to think about, chronic urticaria, dermatitis herpetiformis, I mentioned because, again, it's one of these things that can be itchy before you actually see the skin changes. But if you do see it, you'll get blisters on your elbows and your buttocks, and I'll show you a picture of that in a second. And then lichen planus, again, it's just one of these derm conditions that's quite itchy, and you can see more generalized itch from it. And then lastly, I think prurigo nodularis is super common. Basically, people itch and then they develop nodules from that scratching and itching. And we have some like exciting new treatments around that, which is great, but very common in older patients. And then whenever I see someone who's coming in with generalized pruritus, particularly those patients who do not have a rash, I think about all these systemic causes, which I'm sure you guys are very familiar with, but CKD and liver disease being probably the most common. Malignancy, especially lymphomas, can cause generalized itch, as well as myeloproliferative disease, and then changes in the parathyroid or thyroid as well. Iron deficiency anemia can theoretically cause itch. I would say I check an iron panel in people with generalized pruritus, but I don't find that that's often the culprit. I don't find that repleting their iron does as much as I would like it to do. Chronic infections can cause itch, and I do check that as well. And then diabetes can too. I think it's really important, and kind of a theme of our talk will definitely be that medications can cause a lot of derm problems, including chronic itch. These are the ones I always look at the med list for to see if they are taking, and if possible, stop them to see if that can help with itch relief. And then other things that are on the differential, delusions of parasitosis, really tricky thing that deserves its own other talk, but I think it's more common than we might think. And then you can get these really localized itch syndromes that can be really, really bothersome to patients. So particularly in older patients, we see a lot of scalp dysesthesia where people have burning, pain, and itching of their scalp. And sometimes, ideally respond to local treatment, and that can, but it can be really, really bothersome for patients. And then there are all these localized neurogenic syndromes like brachioradial pruritus, where you get the, itching on just the forearms. Notalgia paresthetica on the upper back is really common in older patients related to nerve impingement at the spine. People can get post varicella itching as well. That can be quite bothersome, and then anogenital pruritus as well. So those aren't quite in the generalized pruritus category, but they're quite chronic and quite bothersome and can be difficult to tackle. But one other thing I just want to mention on this page, one study I found that showed that 16% of patients on statins have chronic pruritus, which I was kind of blown away by. It's like a pretty high amount, but just something to think about. I think a lot of our patients who are on statins, we don't really want to pull them off of statins, but could be a contributor. This is just a picture of Grover's disease, which again is one of these really common rashes in older male patients in particular. You get these really fine small papules and almost pustules on the trunk. It's linked to heat, sweating, excessive sun exposure, and some medications, but we don't really know what causes it. Usually we just treat it with triamcinolone and it goes pretty well, but just something to think about in patients with chronic itch. And then this is a picture of dermatitis herpetiformis, where you get these smaller, really fragile blisters on the elbows and often on the buttocks. that will erode quite quickly. So you may not actually see the blister to begin with. Um, I'd say, in general, I don't see this quite as often in older patients. It tends to present a little bit younger, but just something else is on the differential that you may not have seen before. Okay, so what do we do for evaluation? So in all geriatric patients, I'll get a CBC with DIF, a CMP, LDH to do kind of a basic evaluation for lymphoma, TSH, age-appropriate cancer screening, and then a really thorough med review. And then these are the other additional tests to consider. I would say in the geriatric population, these are probably the ones I focus on. So bullous pemphigoid, ELISAs, SPEP, UPEP, and free light chains. I will often do a peripheral flow cytometry because of this question of cutaneous T-cell lymphoma, and theoretically like an underlying lymphoma as well, like an underlying systemic lymphoma. And then iron studies and A1C, I think are pretty easy to do. Most of these patients will require an A1C just for monitoring anyways. And then iron studies, it's like if we can replete their iron and that takes care of it, great. Like that's pretty low hanging fruit. I don't tend to do a lot of this other workup. I guess the other thing I should add is I often will do an HIV, Hep B, and Hep C, but I think those are usually have been done within the past couple of years, so I don't necessarily reach for them. So what can we do? So that, a lot of patients will respond to just simple non-invasive treatments. So gentle skincare can really make a big difference. So things that we talk about are limiting bathing to 2 or 3 times a week and using soap on only kind of smelly areas. So armpits, groin, feet. Because a lot of the other areas you can just rinse off with water and they'll be just fine. I do encourage patients to use a really mild soap like a Dove bar soap. And then moisturizing all over twice daily with moisturizing creams. So these are the ones that we typically recommend. Lotions, so things like come in a pump bottle, have alcohol in them. And so they tend to dry out the skin more than creams will. So we always go for creams. And then we often will recommend this, what we call soak and smear. So with this, we have a patient soak in a bathtub filled with warm water for 10 minutes. And then immediately after they get out, just pat dry, and then take triamcinolone ointment and rub it all over the affected areas of itch. And then on top of that, put moisturizing cream all over. And basically that works, but after you're in the bath, kind of the pores are open a little bit, the medication gets in a little bit faster, and the moisturizing cream and the triamcinolone will lock in the moisture from the bath as well. And so that can work super well for itch and moisturizing in general. Another thing that I'll recommend sometimes more in the pediatric population, but I will sometimes reach for it in my geriatric patients, is wet wraps. And so basically you do the same thing as you did with the soak and smear. You have them take a bath, put triamcinolone on, then moisturizer on. And then after that, you have them take warm, wet cotton pajamas and put them on top of those layers of moisturizer and triamcinolone, and then put dry cotton pajamas over that and leave it in place for 2 hours or overnight. And it sounds like really uncomfortable, right? To be like sleeping in wet pajamas. But it does really help with itch. And I think even if patients can keep it on for a couple hours, it can make a big difference. And, we have kids do this a lot. And I will say that like a lot of them do pretty well with it. So, I don't think it's quite as bad as it sounds to be wearing wet pajamas, especially if they're warmed up in like if you wet them first and then put them in the dryer to kind of warm them up just a little bit, that can make a big difference. And then the last thing in this kind of simple non-invasive treatment category is phototherapy, which I love for geriatric patients. So with phototherapy, they go to a local phototherapy center. So for us, it's often at UW Roosevelt, though there are many in the community as well. And they, stand under an narrowband UV light for a few minutes, 3 times a week. What is great about phototherapy is that it really doesn't have any side effects. I mean, it is a narrow band of UVB, so the risk of skin cancer is lower than with just regular sun exposure, and the time that you're exposed is so little that it increases skin cancer risk, but not hugely so. And it's in comparison to medications, it really has like few side effects, and people love it. They really feel like it often will help with that generalized itch in particular, and with a lot of other dermatologic conditions. I think the main barrier, including for geriatric patients, is just getting to a phototherapy center 3 times a week. That can be a lot, especially if they don't have their own transportation. And then sometimes insurance does not cover it. So that often will come up with our Harborview patients. The VA, Ruru had mentioned that a lot of people here are VA-based geriatricians. The VA does have a mechanism to have phototherapy at home, which is a really great resource. And I thought I'd just take this minute to just talk quickly about topical steroids and calcineurin inhibitors, because for a lot of dermatologic conditions, including to some extent generalized pruritus, topical steroids are a really easy first line option. And I think the thing with topical steroids is like there's so many out there, but really you just need to learn like one low, one medium, and one high potency topical steroid and just kind of use that as your package to go to. So this is what my general the ones I use. So anything in the face, neck, groin, or armpits using desonide, alternating every 2 weeks with tacrolimus, which is a calcineurin inhibitor. So not a steroid, does not cause skin thinning. On the trunk and extremities, I'll use triamcinolone. And if it is a wide area of involvement, I order a 454-gram jar rather than just a tube because it will last a lot longer. And then on thicker areas, I'll use clobetasol. Again, with both of those alternating with tacrolimus, which is that calcineurin inhibitor. And then on the scalp, clobetasol solution is my go-to there. So your goal overall is to use the topical steroid about 50% of the time to prevent skin thinning. Um, Tacrolimus is often not covered by insurance until you've tried a topical steroid, but after you've tried it for 28 days, you can usually get the tacrolimus, and that can be a really great tool to have because people can use it as much as they want. It's not going to hurt them. It does have a black box warning on it because if you take oral tacrolimus, obviously that can have a lot of long-term impact, but I just counsel patients about that before. If you put it on your skin, it's really not going to hurt you. We use it down to like newborns. Other topical options that can be helpful, Pramoxine and menthol or Sarno, which is a combination of the two, can be really helpful for just as needed use throughout the day to lessen itch. Topical doxepin can also be effective. And then I really love this compounded cream, this amitriptyline gabapentin lidocaine cream. And I use this a lot for patients with scalp dysesthesia and in particular. Um, you have to get it through a compounding pharmacy. So the two that I use are skin medicinals, which usually you need a login account for, so it may not be as convenient for you all. But this other pharmacy called Noblesville Low Cost Pharmacy, you just type the order in Epic, like you would type in amitriptyline, and then the comments add in gabapentin and lidocaine cream to be compounded with it. And then you search for Noblesville Low Cost Pharmacy in Epic and you send the prescription directly to them. And then they basically call the patient and send the prescription to their house. And it's not super, super cheap. It's $45 for a small tube. But it can be super effective, particularly for those like more localized pruritus syndromes. And then we do have systemic options too. These are the two that I use in the geriatric population. So gabapentin, which you're all familiar with. The literature in chronic pruritus has us starting at pretty low doses, like 100 milligrams twice a day. So I'll sometimes start with that. Sometimes if patients have more severe itch, I'll do like 300, 600 at night, particularly because itching in general is really bad at night. And, in pretty much anyone who has itch, it always worsens at night. And then naltrexone can also be really helpful. We usually prescribe that as low dose. So I know there's some literature in like fibromyalgia and long COVID for low dose naltrexone. We use similar dosing where we start at 1.5 milligrams daily and up titrate to like up to 4.5 milligrams a day. If you order it as a compounded low dose is quite expensive, $35 to $70 for a 30-day supply. But there's this other method where you can take a 50 milligram tablet, which is actually much cheaper, and dilute it. And I use naltrexone a lot for other reasons. And so I tend to do this if it seems like patients can manage that, or if they have a family member who can manage it. And then you can use all of these other things as well: mirtazapine, doxepin, amitriptyline, cetirizine. I don't need to stress the point, I'm sure, with you all, but these are really sedating, and so I try to avoid using them um, in elderly patients. Cetirizine is not sedating, but I don't think really works that well. The American Geriatric Society actually says that histamines are not recommended for generalized pruritus unless you think it is more of a histamine mediated urticaria. And I totally agree with that. I think most of these processes are not histamine mediated, so loading people up with a bunch of antihistamines is generally not beneficial. Um, you could consider cetirizine or loratadine, given that they're not as sedating, but I don't think they work super well either. And you can see that the American, oh, sorry, I clicked the wrong thing here. Um, did I click it? Are you guys seeing the wrong screen? I think I just did
Um,
something weird.
yeah, if you do play from current slide, I think that should get you back.
Yeah.
There you go.
Yeah. Here, let's see. Are we
Yep,
back?
yep,
Okay,
that's
great.
good.
Sorry, I just
Great.
moved something weird on my mouse. But you can see that they recommend really similar things in terms of just kind of gentle measures to start. And I do think that works for a lot of people. Okay. I'm going to switch over to indolent drug reactions, but I don't have any questions at this point about generalized pruritus.
I guess I had one question in that if we do feel like it's medication mediated, say from a statin, what would be an expected time course that if we stopped it, that you would expect to see a
Yeah.
change?
Yeah, we're going to talk about that right now, but like usually like it can take 6 months or so. It can take a while. Um, but I think in derm we talk a lot about acute drug reactions, but there are all these indolent drug reactions too. And here again, dermatologists and geriatricians have a shared interest where like cutting out unnecessary meds can really make a big difference. Um, so I'm going to start with just a few pearls, and then we'll kind of go into like each specific reaction a little bit. Um, so I think it's important to think about a drug reaction, basically any geriatric patient who comes in with a new generalized rash, because it is a super common, medications are a super common cause. And a lot of these rashes, looks like it would be a little weird for them to pop up all of a sudden in an 80-year-old without some sort of external trigger. Indolent drug reactions tend to be generalized and they tend to be recalcitrant to standard treatment. So like often will not respond to topical steroids. And then identifying the morphology, meaning like identifying what it looks like. Does it look like eczema? Does it look like psoriasis? Can narrow the list of potential culprits a lot. The latency period between drug exposure and development of rash can be really long. So kind of to Ruru's point, like, how long do you actually stop it for? And how can you identify what drug it is? It can be really tricky. And it can be even like years of being on the drug before they get the rash. And then it can take almost, up to 6 months of stopping the drug for the rash to resolve. Topical steroids and phototherapy are a really good start to treating it. And then, I think if you're not getting success with that, then sending them to dermatology is very reasonable. This slide is just meant more as a reference because I think there are a lot of drugs and there are a lot of different reactions that they can cause. And we'll go through kind of each of these categories quickly. So eczematous drug reactions are pretty common. This is a patient I saw last week who I think has an eczematous drug reaction to amlodipine. Calcium channel blockers, hydrochlorothiazide are really common causes. And then anything that treats psoriasis can cause a shift in the Th1 immune response to a Th2 immune response. And so those are all implicated in eczema-like reactions. Um, and then as well as a lot of these other medications, I think eczematous drug reactions are some of the most common. And so anytime you have someone who's coming in new with eczema, I would do a careful review of their drug list. Um, I want to just focus in on the PD-1 inhibitors like nivolumab and Pembro. They cause a lot of different drug reaction or rashes in general. And they can start within weeks of getting the medication and can develop like up to 18 months into treatment as well. And in general, well, in other situations, we'll stop the medication that's causing the rash. In this situation, we treat through as much as we can. So we try and keep them on their immune checkpoint inhibitor. Eczematous reactions notably are more common in older adults than in younger people. Psoriasiform rashes, so things that look like psoriasis, often are caused by beta blockers, TNF inhibitors. You can get this paradoxical reaction because TNF inhibitors are actually used to treat psoriasis in a lot of people. Dupilumab, again, which is a eczema medication, can shift you into a more of a psoriasis-like immunophenotype, and so that can cause a psoriasis like rash. And then systemic steroids are kind of a no-go in psoriasis in general. They actually make psoriasis worse. Um, so they can also trigger psoriasis. This is a patient, not a geriatric patient, but a patient I have who has a psoriasiform rash from a TNF inhibitor that he was on for ankylosing spondylitis. And we stopped the TNF inhibitor and treated him with other things, and he felt way better, which is great. This is an example of lichenoid drug reactions. Beta blockers, hydrochlorothiazide, and ACE inhibitors are the main ones I think of here. You can get both oral or mucosal, like implantus, or more cutaneous involvement. Subacute lupus has this kind of ring-like scaly plaques. This is a patient I saw a few weeks ago who had SCLE, and this can be caused hydrochlorothiazide, calcium channel blockers, ACE inhibitors. So you'll notice that there's like a little bit of a theme with these antihypertensives being big culprits for a lot of these drug reactions. And these patients are often anti-Ro and SSA positive, and many of them will go on to develop lupus, like 80%, but not all of them. Just in contrast, this is different than drug-induced systemic lupus, which is caused by different medications and often has a different antibody profile as well. Granulomatous skin reactions, you get these kind of firmer, non-scaly, often ring-like plaques, which sometimes will have the central sparing. This is a patient I saw last week who has a granuloma skin reaction from a TNF inhibitor. So again, like a paradoxical reaction because TNF inhibitors are used to treat granulomatous disease in the skin and in other places. But again, like the antihypertensives, beta blockers, calcium channel blockers, ACE inhibitors, Lasix are big ones here. Also immune checkpoint inhibitors. And then acneiform eruptions. I think we see these most often in people who are on systemic steroids or patients who have cancer who are getting EGFR inhibitors or tyrosine kinase inhibitors, MEK inhibitors. Anytime you see pus on the skin, I would consider culturing it because it could always be a folliculitis, and that's something that's relatively easy to treat. And then our treatment is kind of similar to our standard acne treatment, where we do a benzoyl peroxide wash, topical clindamycin, tretinoin, and sometimes, of course, an oral doxycycline. Notably for EGFR inhibitors, these acneiform eruptions are so common that we will often prophylax. So if someone's getting started on an EGFR inhibitor, starting them with actually topical steroids because it's more of an inflammatory reaction, and doxycycline. We tend not to use benzoyl peroxide wash and tretinoin in these EGFR inhibitor patients because it's more drying. And then depending on the grade, we kind of march up our ladder of acne treatment, sometimes getting to low dose isotretinoin and even prednisone. And then drugs can cause blistering disease as well. So they can cause pemphigus vulgaris, which has more of this kind of upper trunk and facial head and neck predominance with flaccid blisters, or bullous pemphigoid, which has more of the tense blisters classically. These are both patients I've seen within the past year who have had medication-induced blistering disease. And the patient on the left with pemphigus, I can't remember, I think it was a antihypertensive. And then the bullous pemphigoid patient was from an immune checkpoint inhibitor. And you can see that looks like a lot like SJS/TEN, and she was actually admitted to the burns unit for that. But pemphigus, again, beta blockers, ACE inhibitors, also beta lactams, and bullous pemphigoid, similar medication profile. I would say what we see more often is immune checkpoint inhibitor causing bullous pemphigoid. One I'll call out here is that DPP4 inhibitors cause bullous pemphigoid, and there's a lot of literature around that. So another one to look out for. So again, this is just like a summary reference slide of what to think about if you have patients who come in with any of these type of rashes. All right. I wanted to dial in a little bit on bullous pemphigoid because this is probably one of the more common skin conditions we see in the geriatric population. Um, this picture on the left is a patient who's currently admitted at Harborview with generalized bullous pemphigoid, and you can see with both of these patients that it looks a lot like what you might think of as Stevens-Johnson's or TEN. Um, and there, in this patient, I think there are fewer clues just based on looking at the picture. But in this patient, you can see there's this tense bulla over here, and that's a little less common in SJST and to have a true tense bulla. Um, so a biopsy can be really helpful and is something I consider in basically any SJSTN patient who is over the age of 50, specifically because I want to rule out bullous pemphigoid. More classically, bullous pemphigoid presents with these tense bullae, really like big round bullae. They often will be on the extremities, the ankles, and the dorsal feet is a really common location for them. But it can present as these more urticarial plaques as well, where you don't necessarily see any clear blisters here. There may be some little vesicles in here. And you could see this person and think about like psoriasis or eczema. But many of these patients who have this kind of urticarial phase BP, meaning like more hive-like plaques to begin with, will then progress to have full-blown blisters eventually. So bullous pemphigoid, as I'm sure you all know, is caused by antibodies to the BP180 and BP230, which are kind of links at the hemidesmosome, so connecting the epidermis to the dermis. It is most common in people older than 60, and the presentation can really range from just generalized pruritus, like we were talking about, to full body desquamation. So I think about BP anytime I have an older patient who has itch without rash, anyone with tense bulla, and then anyone with SJSTN. Most commonly, it's idiopathic, but important to do a med review. We talked about these meds that it's associated with. In particular, I'd call it the immune checkpoint inhibitors and TBP4 inhibitors, the gliptins. There's this really interesting association between bullous pemphigoid and neurologic disease. So it's more common in patients with dementia and stroke, and I don't think we really know why, but just interesting. And then it can be associated with other autoimmune disease as well. For diagnosis, we do a biopsy for both pathology and for direct immunofluorescence, so looking for antibody deposition at the dermal epidermal junction. There's a blood test, which is like easy for any of you to do. If you just type in bullous pemphigoid ELISAs and EPIC, it'll pop up, and that gets sent out to the ARUP lab in Utah, and they do an amazing job. And then looking at a CBC can be really helpful. About 50% of these patients will have hypereosinophilia. Treatment can range from topical steroids to more systemic treatments. And I'm going to talk to you a little bit more about these three treatment strategies because this is probably what we use the most. So there was a study back in 2002 that looked at clobetasol versus prednisone in patients with moderate bullous pemphigoid. And you can see that the efficacy was pretty similar. So in terms of proportion surviving, clobetasol was non-inferior to prednisone. And I think that's really important in management of this because a lot of patients with mild to moderate bullous pemphigoid can be managed with just topicals alone, and saving them immunosuppression can make a really big difference. So, this study was done in the moderate population. There have been smaller studies done in patients with more mild disease, but in general, if patients have more limited disease, I reach for topical steroids first. And then talking a little bit about doxycycline and bullous pemphigoid. So back in 1995, there was this randomized control trial that looked at tetracycline plus nicotinamide and compared it to prednisone. It was a really small study, just 20 patients. In the prednisone group, everyone improved, and 17% of those patients had complete response. In the tetracycline group, not everyone improved, but a fair amount of them did, about 83%. But 42% had a complete response. So we have based a lot of our management of bullous pemphigoid off of this study, and have used doxycycline and nicotinamide as a strategy for people who are kind of in that mild to moderate category of disease, given that they have like pretty low risk profile. There was a more recent study in 2019 that kind of looked again at this question and it included clobetasol in the treatment regimen. So it had tetracycline plus nicotinamide plus clobetasol in one group, and then they compared that to people who were treated with just prednisone. And the median time to control of bullous pemphigoid was really similar for both. It was 7 days for both. And the tetracycline group actually did better at 4 weeks than the prednisone group. Um, and the relapse at 1 year was also lower in the tetracycline group than in the prednisone group. And the tetracycline group had a survival advantage. So all of those things I think support this as a good treatment strategy for people in that kind of moderate to even mild disease category, because doxycycline doesn't have a ton of risks, right? I mean, you have nausea, photosensitivity, it is an antibiotic, and so that's maybe not great in terms of antimicrobial stewardship. But I think just in comparing it to putting especially older patients on prednisone, it's huge. Notably, nicotinamide causes flushing, and all these studies have been done with tetracycline plus nicotinamide, so it's a little unclear if like the tetracycline is driving it or the nicotinamide. We often do not include the nicotinamide when we treat these patients here at Harborview just because of the flushing issue, and it's really hard to get inpatient for some reason. But the studies are based on tetracycline plus nicotinamide. But Dupixent is our go-to. So we in dermatology love dupilumab for atopic dermatitis. We also love it for bullous pemphigoid. And just a quick review of what Dupixent is. So Dupixent or dupilumab is an IL-13 4R inhibitor. It's very commonly used in atopic dermatitis. I'm sure you all have some patients on it. And then it got FDA approved for bullous pemphigoid last year, which was really exciting. It's very well tolerated. It is an injection medication, so you have to do an injection every 2 weeks. But main side effects are that it can cause some conjunctivitis. It can cause injection site reactions, which are, I think more than some of the other biologics that we use. And then there's an increased risk for viral illness. But it works really effectively for bullous pemphigoid. So this is a study out of JAMA Derm. It was a retrospective cohort study in China that came out a few years ago. And they show that patients who were treated with Dupixent, all of whom were over 65, had a really rapid reduction in their BP-DAI score, which is just like a measure of severity. So the severity of their bullous pemphigoid really dropped pretty significantly in just 2 weeks, and their itching did as well. And then it persisted, over 64 weeks. They also found that their serum antibodies dropped. There was a little bit of variability in the BP180 antibodies, but their serum IgE dropped and their eosinophil count dropped as well. And so all of these really support that it's effective in bullous pemphigoid, and it's so much lower risk than a lot of the other things that we use, like prednisone or like mycophenolate, for example, is what our old go-to used to be. So our kind of current strategy for treating bullous pemphigoid, I would say at Harborview and likely elsewhere, is that if it's mild to moderate, we'll put them on topical steroids. If it is more in that moderate category, we'll do topical steroids plus doxycycline. And then if they're more severe, then we'll put them on Dupixent if we can. And then if you can't get Dupixent approved, which is becoming less and less of a problem now that it's FDA approved, then we'll do mycophenolate. That's just our kind of summary of what I just said. So I'm going to move on to non-surgical management of squamous cells and basal cells, and I'm going to be conscious of time, so I may skim over some of the studies here. But just briefly, we usually manage basal cells and squamous cells surgically. That's kind of a standard of care NCCN guideline treatment. So with superficial disease, we'll treat with ED&C, and then with larger or with deeper invasion, so things that don't just involve the epidermis, then we do excisions. And as it gets larger and higher risk, we consider Mohs, as well as in places that are higher risk, like the head and neck, that will go straight to Mohs rather than to a standard excision. And this strategy in general is like 98 to 99% effective. So it takes care of mostly everything. But we do have alternatives. So for basal cell, we'll start with basal cell and then we'll go into squamous cell. So basal cell topical therapies. So for superficial BCCs, a really great treatment option is imiquimod 5% cream. And we put that on 5 times a week. Sorry, yeah, 5 times a week for 6 weeks. So it's like a relatively long treatment course, but you're just putting a cream on one spot. And that has shown around 80% tumor free survival at 3 and 5 years. There is a higher recurrence versus surgical treatment, so 16% versus 1.6% at 3 years. But it is the preferred non surgical treatment by NCCN guidelines, and it is FDA approved. Um, and when I think about using topical imiquimod, I think a lot about just patient quality of life. Like, is it easier for them to put on a cream once a day, or is it easier for them to come into the office and get, for a superficial BCC and EDNC, which is scrape and burn, it's like a pretty quick 5 to 10 minute procedure. And I think it just depends on the patient and the location. If it's a superficial BCC that's on the cheek, for example, a more cosmetically sensitive area, a imiquimod may be a better choice because it's just not as invasive. It's not going to leave a big scar. And it's just a little cream that you put on your face once a week. There is some evidence for 5FU. We tend to use it less than imiquimod just because the success rates aren't quite as high. There's actually some evidence for imiquimod in nodular basal cells too. So EDNC plus imiquimod. So you're doing a scrape and burn and then adding imiquimod versus excision. People who have EDNCs plus imiquimod have 77% tumor-free survival at 5 years, which is less than like the 98, 99% that you would get with an excision, but it's also not that bad and is a less invasive procedure. And here's just kind of the study that's showing the survival difference or the probability of recurrence in those patients. PDT or photodynamic therapy can also be a really good option. Most of the studies in superficial BCCs have been done with this MAL PDT. And basically what they do is they paint on this methylaminolevulate, and then they put them under the PDT light. And then superficial BCCs, there's around 60% tumor-free survival at 5 years. In comparison, like thinking back to the prior slide, that was about 70% for 5FU and 80% for imiquimod. So a little bit less effective, but this is a 2-time treatment. So maybe better than putting on an irritating cream for 6 weeks, maybe better than going through a whole surgery for some patients. There, again, is some evidence for PDT in low risk nodular basal cells. There's a higher recurrence rate, so 36% recurrence rate at 3 years, but again, has improved cosmetic outcomes. And again, when I'm thinking about older patients who have some of these non-melanoma skin cancers, it's a little bit thinking about like what works best for the patient. Does it work best for them to come in twice and have a light shine at them and have some irritation for those 2 weeks? Or does it work best for them to come in for a big surgery? And I think it really just has to be a discussion with the patient. I think with a lot of these patients, their basal cell is not what's going to kill them, right? They have all these other medical problems going on. And so just figuring out what kind of works best for them in their lives is, I think, the best strategy. Radiation can also be used, really high cure rates, depending on the study. There is a slightly higher recurrence versus surgery. But the NCCN guidelines do recommend radiation as a strategy for non-surgical candidates for both high and low risk basal cells. And I think where this comes into play most often is patients with really big tumors, where surgery is going to be a big deal. It has really good cosmetic outcomes, but radiation does require a fair amount of commitment. So it's 2 to 5 visits per week for 6 to 7 weeks. And so that can be really challenging for some of our older patients. And so I think, again, the balance is often like, is it worth the commute? Is it worth the time commitment versus having a big surgery? Again, where I think this really comes into play the most often is in patients who have really big tumors, where the surgery is going to be much higher risk. For squamous cells, all topical treatments are off-label. However, the NCCN does recommend 5FU plus minus calcipotriene, which is a vitamin D analog, as the preferred treatment for squamous cell in situ. So squamous cells that involve just the top layer of the skin rather than invading down into the dermis. And for people with field cancerization, what field cancerization means is patients who have like confluent actinic keratosis. So people have a lot of sun damage that is either pre-skin cancer or kind of evolving into this squamous cell in situ where they have just the top layer of the skin. And our regimen for this is 5-FU twice daily for 4 weeks. And we've found that in general, a 5-FU works better than imiquimod for squamous cell in situ. It has higher clearance rates. Um, and so that tends to be what we'll use rather than imiquimod for squamous cells. For invasive squames, there is not really good evidence for using topical therapy. The topical therapy likely does not penetrate deep enough. Oh gosh, I just did the same thing again. Oh my gosh. Give me 1 second. Um, doesn't penetrate deep enough into the dermis to make it effective. And so we really don't use topicals that much for invasive squamous cells. And invasive squamous cells are just like that much more dangerous than basal cells are. PDT, again, the data is mostly in support of its use in the top layer of skin, squamous cells, the squamous cells in situ. The photosensitizers do not penetrate into the dermis. We don't use it for invasive squamous cells. But again, you can see that they're like pretty good clearance rates, 80% clearance rate for PDT for a squam in situ. So again, a really reasonable option, something I'll turn to sometimes. This is just a meta-analysis that looks at the rates of recurrence in squamous cell in situ treated with different modalities. They had included 186 studies with about 9,000 tumors. And so you can see that the rates of recurrence are higher for some of the topical therapies like 5-fluorouracil and imiquimod and photodynamic therapy. But again, they're not super, super high. It's like a 25% risk of recurrence. And so if you have, an 85, 95-year-old patient who has a, shorter life expectancy and has other medical problems, these risks may be acceptable in comparison to putting them through a surgery. Radiation is a great tool for a squamous cell for non-surgical candidates. In particular, when I think about patients who have bigger tumors, I think this is a really great option. This is the patient I had who had radiation and that tumor basically just disappeared. It has a local control rate of almost 90%, and recurrence is higher than it is for surgery, but around 10%. For patients who have a huge squamous cell who is going to involve like a really big surgery, this is an excellent option and is NCCN guideline recommended. The tumor stage does significantly impact outcomes. People with a higher tumor stage do worse, but it does have better cosmetic results than surgery. Again, the regimens vary, but it does require a bit of a time commitment. But in cases like this, where the tumor is huge and could potentially require amputation, if you were going to surgically excise this, radiation can be a great option. And then lastly, I want to talk about active surveillance. So active surveillance, I think, is a really great option for older patients. So there have been several studies that have looked at patients who have just had a shave biopsy to diagnose their lesion and then were followed, meaning they did not have any topical treatment, they did not have surgery, they did not have radiation. And in this study of 89 patients with both low and high risk basal cells, about 8% developed new tumor symptoms like bleeding or crusting, and 38% stopped active surveillance and were treated. So 60% of those patients didn't require any further treatment. Similarly, there's a cohort study of people who had squamous cells and squamous situs that appeared to be clinically resolved after biopsy. And only 1% of the squamous cell patients and 4% of the squamous cell in situ patients recurred locally. So, really low rates of recurrence if you can clinically just remove it with a shave biopsy. And this chart is just from one of these studies, and it just shows the reasons why people chose to pursue active surveillance, which I think is, relevant to a lot of your patients. Too many stressors in their life, hard to get to treatment. They were worried about the cosmetic outcome. And I think and then, frailty being a big chunk of these patients down at the bottom of that slide. So I think that depending on the patient, this can be a really reasonable strategy. And I will say in practice, we do this a fair amount. If we take out a biopsy and it says margins are not involved, we'll often just follow it clinically and just see how things go. So in terms of take homes here, non-surgical management is somewhat less effective than surgery, but it may be an acceptable and even preferred option depending on the patient, particularly in the geriatric population. Topical therapies are more effective with superficial disease rather than deeper disease, and so we tend to reserve them for that. But radiation can be super effective. That does require more visits. And then I would consider active surveillance depending on the patient's goals, particularly, depending on their life expectancy. If they have other stuff going on in their life, their basal cell is probably not going to be their biggest issue. And so I think it's really reasonable to just watch some of these patients. Okay, that is it. It's a lot of information. And I didn't leave super much time for questions, but if anyone has any, I'd be happy to answer them.
Yes.
This is my non-geriatric daughter putting on sunscreen. So
We've got one question that's in the chat from Wayne, and he says he's asking about SKs and are there any good topical therapies
yeah,
as
that's
opposed
a
to
great
freezing.
question. There aren't really. I wish there were. Freezing's our go-to. Sometimes we'll recommend amlactin. So for people who have a lot of SKs, particularly I don't know if you know those like steccokeratoses, these like really like white kind of thin ones on the ankles. Amlactin twice a day can be helpful for those, but it's not like a magical cure. I think whoever comes up with a magical cure for SKs will make a lot of money. Other questions I can answer?
I really appreciate your overview of the non-surgical issues approaches to SCC because I definitely feel like I have nursing home patients who it's really hard to get them out um, uh, with transport with behaviors, and so they may have had an initial diagnosis and perhaps an excision. And if it
Mm-hmm.
becomes hard to actually get them in for surveillance visits due to their dementia and behaviors, would you
Yeah.
say you could like sort of like prophylactically apply um, topicals
Huh.
in case there
Yeah.
is concern for recurrence?
Yeah, I mean, I think particularly in those people with like more superficial disease, that's a reasonable strategy. And we do use Fudex and calcipotriene for actinic keratoses. It's a shorter treatment regimen, but that can be a really good strategy too to prevent progression of disease. But I do think that that issue comes up a lot. And the other situation that comes up a lot is patients who are like very frequently hospitalized or have a prolonged hospitalization where management of their skin cancer is just not really feasible in the inpatient setting. So I think it's reasonable even from like a palliative standpoint to consider doing it. I think the con of it is that the creams are quite irritating, and so like to put them through that may not be worth it risk benefit wise.
Um, all right, you have some other chats of appreciation. That was incredible. Excellent
Yeah.
presentation.
Yeah, thank you. And please reach out if any questions come up. I'm more than happy to talk with you. And I know many of you are based in Harborview, so feel free to pop over if you have a question.
Thank you
Thank
so much.
you. Thanks so much.
All right, thanks everyone.